It is an honor and privilege for me to introduce our first keynote lecturer for this Congress, who is none other than George William Aylward, better known to us all as Bill Aylward, who is going to give us his presentation on the evolution of retinal surgery.
Well, Tom, thank you very much indeed for that very generous introduction. It's an enormous pleasure to be here, and thank you for Jan and Suzanne and the organizing committee for the invitation. About 10 years ago, I gave a talk in Barcelona remotely from Moorfields. Perhaps it was a bit more than 10 years ago. And it seemed to be a good idea. I thought this is really cutting-edge technology. We can save the planet by traveling less. And I finished the talk, answered some questions down the phone, and then while everybody else went out onto the balcony and had tapas and kava, I had to go back to the clinic. So that was the first and last time I did that. So it's a great pleasure to actually be here physically to talk to you. There's a couple of disclosures which are basically nothing, no financial interests of any sort. So at this stage in your career, when I'm not operating anymore, not innovating, I tend to get asked to talk about history, but I think it's quite important. It's more than just a curiosity. It's very important to study it so we understand how we got where we are and avoid repeating the mistakes of the past, a lesson that many of our politicians should also learn. So I make no apologies for talking about it. And whereas natural evolution has major leaps, so is the same for the evolution of academic subjects and indeed surgery. And I'm going to structure the talk about a number of leaps which I personally think have been instrumental in taking us to the present day. There are only 5 of them, and it is a very personal choice. The first, of course, is the ophthalmoscope, 1851. But interestingly, before that, a very innovative surgeon in Scotland, James Ware, in 1805, succeeded in diagnosing and operating on a retinal detachment. I presume the retina must have been visible on the slit lamp or with a hand torch, because there was still 40 years to go before the ophthalmoscope appeared. And this is a really interesting paper. And I don't know if you can actually read the text on the right, but what he did was stick a needle through the sclera, and a yellow fluid came out. And what it says there is sufficient in quantity to wet a common handkerchief, which is not something we all necessarily have on our scrub trolleys anymore. And the tension of the eye was considerably diminished by the operation. Unfortunately, there's absolutely no follow-up on the patient at all. And in the same paper, if you look on the left-hand side, there's an appendix on introduction of the male catheter and treatment of hemorrhoids. So he wasn't exactly a subspecialist. But then, of course, the ophthalmoscope came along, and this was an enormous leap. We could finally see what was happening inside the eye. And Helmholtz was largely responsible for this. An extraordinary, brilliant man whose interests knew no bounds. And I think we're very lucky that he spent any time on optics at all, given his range of interests. And not many people know that among all his achievements were his insights in physics. So he was the first to come up with the whole idea that motion, heat, potential energy were all equivalent, i.e. conservation of energy. And he also was the first to predict the heat death of the universe. So we're quite lucky in his spare time he invented the ophthalmoscope, I think. So now what? We could now see in detail retinal detachments and other retinal pathology. And the question was how to treat it. Because James Ware's technique, when it was done, the fluid kept coming back. So it was effective initially, but how to stop the fluid returning. And remember, at this time, there was not a full understanding of what was going on. And von Graefe came up with the not illogical idea of draining the fluid into the vitreous permanently by making a hole in the retina. Now, of course, we look back on that now and have a bit of a laugh, because clearly that could not possibly have worked, given what we know now. But at the time, it seemed very sensible, because it was a permanent route of drainage for the subretinal fluid. It didn't involve making repeated holes in the very vascular choroid, which was a little bit scary. And it was quite a sensible idea, but it was ultimately rejected, and we now know that it couldn't possibly have worked. But one interesting thing about looking back on this is that if we go to the present day, there are many, many things that we think now that will turn out to be wrong in the future. And just to give you an idea of the scale of that problem, I have this data from a paper only a couple of years ago on what is called medical reversals. So a medical reversal is something that you think is a good idea and you're actually doing with all the best will in the world, and it turns out to be wrong, harmful, or simply ineffective later on. And this is a very interesting study. This looked at a large number of articles, and when I say articles, these tend to be meta-analyses or major reviews, very highly cited, so serious articles over a 10-year period. And what they found in the subjects looked at, you can see the figures there, but basically only 38% of what they looked at turned out to be reaffirmed. 22% were inconclusive, and 40% were reversed. Now, if you extrapolate that, that sort of means that 40% of what we're doing in our practice, as of today, may well end up being reversed in the future. And that was the position von Graefe was in. Argyll Robertson, of the pupil fame, made a contribution because he thought, well, let's get a permanent drainage of the fluid. And we can do that by making a hole that stays open, trephination. And although that didn't turn out to work for retina, that was probably the start of drainage surgery for glaucoma. Now, one very interesting technique that was introduced at the time and is still done and has an evidence base behind it was bed rest and patching. When I say still done, we tend to rush into theatre these days, but only a few decades ago, when patients used to come in and be bed rested, it was clearly effective in terms of reducing the detachment, not permanently, but temporarily, so that we could use perhaps a less invasive technique. And the ways of immobilization used were atropine for immobilizing the pupil, and sandbags and double padding. Double padding always, I felt, was a bit strange because of rapid eye movement sleep. You know, what is the point of patching both the eyes when for half the time when you're asleep, your eyes are moving all over the place? And I'm going to address that in just a moment. It does work, and here's a paper from 1977, immobilizing by traction sutures, which is a bit more of a direct way of immobilizing the eye, but also bed rest. And you could see that 45% of retinas were attached the next day, allowing the surgeon to use a much less invasive and minimal technique. So it is something that works. Why does it work? Because of reduction in fluid currents. And this is something that Robert Mackimer had a lot of insight into, and he presented his work in his Jackson Memorial Lecture to the Academy in 1984. But before that, Linder, the Austrian retinal surgeon, did a fantastically elegant experiment, which is illustrated on the right here. And what this is a flask which he has coated with a layer of gelatin. And then he's made a nick in the gelatin, modeling a retina and a retinal hole. He then filled the flask up with water and would twist the flask, the neck of the flask between his hands to simulate saccades. And what would happen is the gelatin would come off the flask, i.e. simulating a retinal detachment. And this was a very important insight into the role of fluid currents. And in scientific terms, this is something called shear stress. So shear stress is the tendency of fluid moving parallel to a surface to effectively go through a hole, to simplify it a little bit. So the more shear stress you have, the more likely fluid is going to go through a hole and detach your retina. And I'm going to show you a video which illustrates this in action. So just to describe the setup before I have this running, this is a video taken during a vitrectomy for retinal detachment. There are several holes. The vitreous cutter has removed most of the vitreous and also quite a lot of the subretinal fluid. And at this point, the ports are closed and the infusion is off. So there's no fluid running in or out of the eye. And what I do is make a few saccade movements, not for this purpose. It was only later, looking at it, that we realized the effect. So you can see the level of detachment there. And then the saccades are really because I'm looking around the eye to see if there are any more breaks. They're quite sort of fast movements. And those movements are fast enough to set up a fluid current and shear stress around the breaks and have, in a few seconds, recruited an enormous amount of fluid under the retina again. So that was before the saccades, and that's after. So that's shear stress and fluid currents in action in an eye. And you can do a little bit of calculation here. This, I think, is the only formula I'm going to show you in the talk. But essentially, it allows you to calculate shear stress, which is related to the change in velocity. So the higher the velocity of a saccade, for example, the more shear stress you will get. And this led to a very important insight for me, because for years, about 30 years, I'd been telling patients that they don't have to worry about keeping still or resting, because the movements transmitted to the eye by movements of the head were much, much less than movements of the eye itself, for example, while reading or rapid eye movement sleep. It turns out that that advice was completely wrong, another medical reversal. And you can calculate it. So let's imagine there's a tear at 3 or 9 o'clock, so that the fluid, when you do a saccade to the left and right, is moving over that tear. And we know what a standard saccadic velocity is in degrees per second, and the radius of the eye, and you do the calculation, it works out that the speed, the maximum speed over the tear is 14 centimeters a second. But the point is, when you move your head, it's rotating around the neck, not around the middle of the eye, and that's a much greater radius. So although you can't do the same saccadic velocity in degrees per second, the radius means the velocity at the eye is double what it is for an eye movement. So in fact, head movements are much, much worse than eye movements when it comes to shear stress, which might be the way that double patching works. Double patching can't stop you moving your eyes much, but it certainly stops you moving your head much because you're confined to bed. So that's a little insight about bed rest and patching, which is still a useful technique for those hospitals that have the resources to admit patients a little bit before, which are getting fewer and fewer. But of course, the second of my big leaps was closing retinal breaks. And this was down to the amazing work of Gonan, who introduced ignipuncture. And he probably did the first in about 1913, but kept his powder dry for a few years for reasons that will become clear in a moment. He nearly got the Nobel Prize for it, but the committee had one reference which said, not so sure, so they didn't do it. But at least the Swiss have named a whole road after him, which is some sort of memorial. He, like Helmholtz, had an amazing brain. He was an extraordinary linguist and was interested in many things and wrote a definitive thesis on butterflies. But it was while he was professor at Lausanne that his seminal work was done. And his insight was to realize that the retinal break caused the retinal detachment, but also that if you closed and sealed the retinal break, the detachment would go away. And what he did, a bit of bed rest to reduce the amount of fluid. He'd localize it very, very carefully indeed on the outside. Using a direct ophthalmoscope, he'd work out the exact point on the outside where the break corresponded to. And then he would stick a graphene knife through to drain the fluid, and then, and this was the key, apply the thermocorter, which is essentially a hot needle, And what that did was it made contact with the retinal hole and burned the edges of it, so that if it was then in contact with the choroid for long enough, it would form an adhesion. So he was draining, closing, and sealing the break. And this is from his book. If you look at these illustrations, they would not be amiss in any modern textbook on retinal surgery after pretty much any technique that we now use. Before there's a detachment, and afterwards there's an attached retina with a choroidal adhesion around the break. So that was a massive step forward. And in doing so, he established the techniques that for retinal detachment surgery, or the principles rather, that we still use today. So however you care to do it, you need to close the break for a short period of time and then seal it so that that seal is then permanent. And the success rate went from virtually nothing to 50% overnight. It was about 1923, 10 years after he did the first case, that he began to publish results. And as he predicted, no one believed him. And there's this wonderful photograph of a meeting at Utrecht with Wavy, Aruga, and Amsler, who he's sending out in different directions in Europe to take his ideas to the world. So that was an enormous leap. But what about the other 50%? It soon became clear that there were other problems. Gaining apposition of the retina and the choroid, and maintaining that apposition while the adhesion developed. So if you had any increase in fluid before the choroidal adhesion had developed, the case was lost. You had to keep that contact. So people thought, well, how can we address this? And one idea was shortening the sclera. You couldn't make the retina go out, so you bring the sclera in. And Shapland was one of the proponents of this at Moorfields. And this is one of his pictures. And if you look at that picture on the right, if you look at the lesion on the left, which is where the scleral shortening was, it looks a bit like a buckle. And in fact, that's what Shapland thought as well. And indeed, Custodis. He thought, yes, this is actually a buckle. That's how it's working. It's not the original idea of how it's working. It's working by generating a scleral buckle. So Custodis then took that to its logical conclusion and realized that you could then just use anything on the outside of the eye, an implant or an explant, to create a buckle without needing to do the scleral shortening procedure. He also, of course, worked out that drainage is not always necessary and started the whole movement of minimally invasive retinal surgery. So that's a sort of chain of reasoning: no apposition, scleral shortening, scleral buckling, explants, of how that development occurred. Now I'm just going to talk a little bit about encirclement, because where did that come from? Well, it came from two sources. One was Schepens, who and his group in the States, who were buckling a lot, and they said, well, if there are holes in 3 quadrants, we might as well continue the buckle all the way around, rather than putting segments on every single break. And Duke Elder felt the same. But it also came from another source, because you remember this picture. This was Aruga, and Aruga also did scleral shortening, but with a ring. See, the Aruga string going all the way around the eye. So this was an original attempt to reduce the size of the sclera. But again, it was effectively encirclement. So the original reasons for circlement being introduced was for buckling breaks in more than 3 quadrants or reducing the size of the globe. But those original reasons got forgotten, and this is a very important other reason for studying the history of ideas, because after a few years, people forget why something was introduced and introduce new justifications which may not be valid. And here are a collection I've got from various textbooks. So this is saying that we need a permanent buckle. This one's saying, oh, we need it for missed breaks. This one's saying it's good in aphakia. And you've probably all heard these reasons. And supporting the vitreous base. None of these reasons had any evidence base at all. They were just introduced after the fact. And I'm going to give you another example outside of retinal surgery, in fact, outside of medicine altogether, which always gives me a chuckle. And that's this. If any of you in the audience make pastry, you've probably read a recipe that says you must sift the flour first. And if you read any textbook like this is Delia Smith, who's the doyenne of cooking in the UK. She says sifting is done to give the flour an airing. That's complete nonsense. This is why sifting was done, because when flour used to be sold in grocers, if you look in the bottom left, there's a sack which could be flour. You buy your flour from that sack and take it home in a bucket or a bag, and it would be teeming with weevils. And the reason for sifting the flour was to get rid of the weevils, pure and simple. And when flour then came in sanitized packets that were guaranteed weevil-free, it was no longer necessary. But people carried on doing it and justified it with different reasons. But just as sifting is no longer necessary, neither is encirclement. So my next leap is going inside the eye, and pars plana vitrectomy. And probably the chain of events goes back to an extraordinary man called David Kasner, who was a cataract surgeon in Miami. And he did some work at the Bascom Palmer Eye Institute. And he dealt with a lot of cases of vitreous loss and became a real expert at the sponge and scissors technique. And when faced with eyes for which there was no other operation, he thought, well, let's use this to get rid of hemorrhagic vitreous or infected vitreous. And in fact, it was amyloid was the first formal case he did. And he simply used sponge and scissors all the way down to replace the vitreous. And many advances are due to serendipity, because at that same institution was a young doctor that came over from Europe and was very interested in what Kasner was doing. And his name was Robert Mackimer. So he saw Kasner doing this operation and then disappeared into his garage for a few months, working with an engineer called Jean-Marie Perel, and came up with this. So this was Mackimer seeing Kasner doing this amazing operation, removing the vitreous, but thinking, can we do this in a better way? And this was the first pars plana vitrectomy that we know about in the literature. Although I have heard recently that the Japanese had done something similar, and it's in the Japanese literature, but in Japanese. Very shortly, other engineers like Conor O'Malley got involved and managed to reduce the size to 20 gauge and have a 3-port system rather than a big, bulky single port. And also with a movement that was up and down rather than rotary, because the rotary motion of the vis tended to suck vitreous in. And that system stayed with us for 30 years until small gauge vitrectomy was introduced about 10 or so years ago. But the reason it's a leap is the step of going inside and making holes that you could take instruments in and out of, meant it opened up the field for a profusion of instruments that could do any number of things. So forceps, sithers, diathermy, laser, the Charles flute, etc. It really was a golden age of developing new instruments to do different things inside the eye. Fantastic period in the early 70s. And also it gave the opportunity to put stuff in the eye. Gas, various liquids, oil, etc. So this is the fourth of my evolutionary leaps. And lots of people involved, because Ohm back in 1911 had decided it would be a good idea to put air in the eye as a primary treatment. Rosengren had introduced the term tamponade. But Ed Norton and Harvey Linkoff as well both introduced expansile gases. SF6 was the first of these. And this was an extraordinarily useful advance because it allowed us to do long-term tamponade. And Ed, an extraordinary character. I was very fortunate enough to meet him, and I apologize for the hat in that picture on the right. That was back in '93. But he was one of those real unsung heroes. He did many advances on his own, but his enormous contribution wasn't the advances he did. It was introducing the whole concept of an institute to Miami the Bascom Palmer, which has since become the leading US eye hospital and one of the best clinical research institutions in the world. And it has spawned any number of retinal advances, including all of Mackamer's work and Don Gass, etc. So really, he should have the credit for all of that as well as what he did with gases. An extraordinary man. Just a little diversion on tamponade, because this is a current controversy, just to bring things up to date, and may well be the beginning of another medical reversal, but we'll see. But I think most people think that tamponade works like this. So you have a hole, and you position your patient so that the gas bubble is up against the hole. And the surface tension of the gas bubble stops fluid going through the hole long enough for the chorioretinal adhesion to develop, and then you no longer need the gas. And that's how most people believe that gas bubbles work. But there are a few problems with that. It means that positioning is absolutely key. And however much we harangue patients to position, most of them probably don't. I mean, I know I'm the world's worst patient when it comes to compliance. And if a doctor gives me a course of 5 days of antibiotics, I'll probably take the first 2. So the idea that patients actually go and do what we tell them is a little bit of a fantasy. This is my colleague Tom Chang, who has advocated posturing for pneumatics, for inferior brakes. And you can see there that looks a little bit uncomfortable on the top. On the bottom, I think what he's done is broken the spine about the level of T4 to allow the head to hang down in a bit more of a comfortable position. But really and truly, patients are not going to do this. So if you consider that model that I described of the way gas bubbles work, you can make a few predictions from that model. You would expect that failures from retinal detachment from inferior brakes would be due to inferior brakes opening up, not with PVR, just opening up because they weren't held in position long enough for an adhesion to develop. You'd also expect a higher success rate with better posturing, positioning. And you'd expect a higher success rate with supplementary buckle for inferior brakes. Well, having looked hard over many years, there is no evidence for any of those 3 things, which should make you call into question the original hypothesis. And going back to fluid dynamics, and no more calculations, I promise, but the question is this. If you have an inferior brake and you have a gas bubble in the top of the eye, i.e. the patient is not positioned so the gas bubble is touching the brake, it's simply in the same eye. So the question is, could that gas bubble have any effect on the shear stress on the brake at 6 o'clock? And to answer that question, you do need to do some fancy computational fluid dynamics. It's not a simple calculation. You need a big supercomputer and a very bright scientist in the form of Ian Eames who can set up the calculations. But if you do that, it turns out that the answer is yes, it does have an effect. So the x-axis is the percentage of gas bubble, and the y-axis is shear stress on the brake at 6 o'clock. So if you have a 50% gas bubble, even though it's miles away from the brake, if you look at the graph, it's halving the shear stress as opposed to there being no gas bubble at all. So perhaps gas bubbles work in a different way from what we think. Maybe it's both, but that's something to watch over the next few years. Perfluorocarbon liquids, of course, have the opposite to gas. They sink in the eye, have been outstandingly useful, and were introduced by Stanley Chang from something that was used as a blood substitute. And you can see in the animation the way it works pretty much the time in retina. You put it in, it squeeges the subretinal fluid out of the brake and flattening the retina. And this is a very popular technique. In fact, many surgeons use perfluorocarbon liquid to attach the retina in almost every case when they're employing vitrectomy. If you look at that graph, you can see that in Africa and the Middle East, it's nearly 73% of respondents use it in every case. In Europe, we're a little bit less, and in the States, not so much. But that has been a very popular adjunct, and of course would not have been possible without the step of going into the eye that Mackamer introduced. And I'm showing you this video because it's the only video in my entire career I've got showing this phenomenon. But it's very, you can see in the middle, I hope, that little stream of Schlieren coming out of a break that you can't quite see. And you can see it now that the video is still at the end. Now, why are you seeing that? The reason you're seeing that is that the density of the subretinal fluid is different from the preretinal fluid. So they have slightly different refractive indices, which is why you actually see it, because they're both essentially clear fluids. Unfortunately, most of the time, that difference isn't there, which is why seeing a break by Schlieren coming out of it isn't a very useful technique. But going back in history, Knobloch, back in 1933, ages before vitrectomy, came up with this idea of injecting fluorescein. And Alistair Laidlaw, who's Thomas's, when he was working at Moorfield, said, well, why do we do that? To help us find little breaks. And we did try it, but unfortunately it was a disaster on two counts. Firstly, the fluorescein got into the preretinal space as well and started fluorescing so that neither of us could see anything. And it hung around so much so that when we did the laser, it fluoresced the laser to the other side of the filter, nearly blinding me. So it was not a great success. But then we had other dyes come along. So when trypan blue was introduced, we thought we'd try it with trypan blue instead. And the idea is you inject it in the subretinal space and get it to come out of the break. And Alistair's pursued this technique and shown that it's not you don't need it all the time, because most of the time you can see breaks. But when you do need it, because you can't find a break, it is a particularly useful technique. And this is a rather nice video showing it. So there's the dye being introduced into the subretinal space. And you need quite a lot of it. And once it's spread in the subretinal space, you then inject perfluorocarbon liquid into the pre-retinal space, and that squeezes the fluid peripherally. At the moment, it's just hanging around the back. And here's the perfluorocarbon liquid going in. And that's pushing the subretinal fluid peripherally and anteriorly and upwards. And there, in the top left, you see it. There's a dye coming out of a tiny break that we couldn't see otherwise. And the beauty of this technique is not only does it show you where the break is, but you see that sort of band at the top, you can guarantee that there isn't a break there. So it shows you where the break isn't, which gives you great confidence in minimally treating the breaks that you do find. So our next leap is subretinal surgery. This was the next frontier. And it's the last of my big leaps, because this spawned a lot of things. And Matt Thomas was really responsible for this. He had a lot of patients with POHS and choroidal neovascular membranes, for which at the time, remember, there was no treatment. This was a long time before anti-VEGFs. And he got outstanding results with a technique which is similar to this, using a 33-gauge cannula of his own design after vitrectomy, putting it into the subretinal space and injecting to separate a layer, and then manipulating the membrane, and you can see that just under the surface there, and then putting in forceps, grabbing the membrane and removing it. And he discovered you could do this without hemorrhagic complications, without having to close the hole, and you could do quite a lot in the subretinal space. The results were extremely good to begin with. For POHS, all those dots in the right part of the scattergram there at the bottom right. But for AMD, which are the yellow dots, no difference at all. And the reason for that is that the membranes in AMD are under the retina, under the RPE. So when you take out the membrane, you take out the RPE as well. So all you do is convert wet AMD into geographic. Whereas for POHS, because it's in front of the retina, the RPE, you leave the RPE intact. And that's why sometimes you get visual improvement. But the whole thinking about this then led to Makaba come up with the idea and his name does keep coming up in this talk, quite rightly too, of rotating the retina. And this was an extraordinary operation, a vitrectomy, 360-degree separation of the retina from the periphery, rotating the retina and putting it back so that the macula was then in contact with RPE again. And he presented 3 cases back in '93, one of which had good vision but had terrible cyclotorsion, and 2 with severe PUR as well. But that led to these 2 surgeons grabbing that technique and really developing it, doing all the hard work of going up that learning curve, rotating the eye in the opposite direction to deal with the cyclorotation. And really extraordinary surgery using all the techniques and knowledge that had been accumulated throughout everything else I've been telling you about in the talk. And they deserve enormous credit for pushing back that surgical frontier. And there was a time about 10 years ago when if you had subfoveal choroidal neovascularization in AMD, then this was your best option. It wasn't university available because surgeons that just did a bit never really went up the learning curve. But if you could get yourself to Klaus or Cindy Toth with this condition, you would get a good result. But then, of course, the whole anti-VEGFs came along and have made a lot of that redundant. And you might say, well, why have I got this as an evolutionary leap when people hardly do subretinal surgery or retinal rotation anymore? And of course, you can say the same for Concorde. You know, why did we bother with all that money developing a supersonic airliner when we don't use it anymore? And the answer, of course, is that although Concorde's not flying, it spawned Airbus, which is very much an entity. And in the same way, that leap of going under the retina allowed, and all those techniques that were developed, allowed the next generation of techniques, including choroidal surgery and RPE translocation, which is extraordinary surgery that Jan van Meurs has been instrumental in developing it. And what this is really the last frontier, because what it means is now we can operate on the choroid, we can operate on every part of the eye, which is a very neat place to wind up. And you might expect me to speculate a bit on where things are going in the future. It's a very dangerous game, and I'm very aware that other people have got it spectacularly wrong. So this is Lord Kelvin of the temperature scale, who made a couple of very public predictions about the future. One saying that aircraft would be impossible, only 7 years before the first one took off. And second, about physics, saying that everything had been discovered, only 5 years before Einstein described special relativity. So I think it is a little bit dangerous predicting the future. But perhaps I would say that visualization, robotic surgery are going to help in some of the details, because although we can access every part of the eye, it's still not practical to operate on the vasculature and some of the finer details of the layers. So I think, in summary, learning from history is important because it gives us insight into the present. And remember that what we do now might be wrong, and certainly why we think we do it might also be wrong. And ideas have their time. Knobloch's idea took 60 years to be developed into reality. So thank you again for the invitation, Thomas, and thank you very much for your attention. And it's a real pleasure to be here. Thank you.